Good afternoon and welcome to our medical lecture series. I am Dr. Khaled Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everybody joining us today. During this interactive presentation, you have the ability to ask questions via the Q&A feature located at the bottom of your screen. I will be your moderator in today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Angel Alejandro. His presentation is titled Beyond Glycemic Control, an update on the cardiovascular benefits of sodium glucose cotransporter 2, SGLT2 inhibitor therapy. Dr. Angel Alejandro is a board-certified endocrinologist at Baptist Health. He specializes in diabetes, thyroid care, and osteoporosis. Dr. Alejandro obtained his medical degree from the Weill Medical College at Cornell University in New York City. He completed his residency in internal medicine at the University of Miami Miller School of Medicine, Jackson Memorial Hospital, where he also completed a fellowship in endocrinology, diabetes, and metabolism disorders, and served as a chief fellow. Dr. Alejandro joins Baptist Health from Leon Medical Center in Miami, where he served as a director of endocrinology and played a key role in establishing programs using technology for diabetes control. A member of the Endocrine Society, his research currently focuses on osteoporosis and reducing fractures in women and breast cancers. He most recently published an abstract in the Endo 2022 conference. So please, let's give a warm welcome to Dr. Angel Alejandro. Thank you so much, Dr. Alejandro, for joining us today. The floor is yours.
Well, thank you so much, everyone, for joining us today with this webinar. The title today is Beyond Glycemic Control, an update on the cardiovascular benefits of SGLT2 therapy. When we talk about diabetes, it would be easy if diabetes was just about insulin resistance and lack of insulin secretion. But we know that diabetes is much more complex than that. And if you see this figure here, this comes from Dr. DeFranzo. This is a lecture he gave back in the ADA in the 2000s, where he said that diabetes is not just about lack of insulin secretion, nor is it just about insulin resistance, but diabetes is caused by multiple factors that interact. For example, he mentioned how the liver overproduces glucose in those patients with type 2 diabetes, secondary to excessive glucagon secretion. This is why those diabetics, they wake up in the morning and they say, Doc, my sugar is high. I don't know why. I didn't eat anything. Well, that's true. You didn't eat anything, but your liver is making too much glucose at night. He mentioned about, obviously, the muscles, lack of uptake of glucose in the muscles. He mentioned the brain. Why do patients with diabetics, why are they always mostly obese when they have type 2 diabetes? Is there some kind of neurotransmitter dysfunction as part of the disease? And then finally, he commented on the kidneys and the gut. And we're going to focus today on the kidneys, because he said it very clear that he felt that diabetics reabsorbed glucose too much and that was a problem. And when he mentioned that, that was a novel idea. Now we know that type 2 diabetics reabsorb too much glucose and it adds to the hyperglycemia we already see. Now, why is this important? Because we don't attack diabetes just by stimulating the production of glucose. We will now treat diabetes by addressing all of these things. And we have agents or medications that help us address these issues. For example, we're going to talk about the SGLT2 inhibitors. They work on the kidney. In the future, we can talk about GLP-1 agonists. They work on the brain and they work with insulin secretion. We know about metformin, which inhibits hepatic glucose production and improves muscle uptake in terms of glucose. So we're going to focus on the kidney today, but just keep in mind that there's many factors that go into the treatment of type 2 diabetes. Now, I put this up there. This is from 2009. Okay, we're in 2023, obviously, but I just wanted to remind you how far we've come in such a short time. If you look here, this is the ACE, the American Association of Clinical Endocrinologists algorithm for glycemic control back from 2009. And at that time, we only had metformin, DPP-4 inhibitors. We had a GLP-1 agonist, but it's not the once weekly ones we're used to now. We had exenatide, right, which is twice a day. We had TZDs, and we had urate carbose inhibitors. That's all we had. And at that time, what did we do? We started everyone on diet modification. Then we started metformin, and then we added something to the metformin. And when they failed that, we added something else, and we just kept adding things. If you look here, this is the ADA guidelines from 2015. In 6 years, nothing had changed, right? There were more agents, right? Now you see the SGLT2 inhibitors are here, and you see more GLP-1 agonists there. At this time, we had liraglutide, okay? And we had once weekly exenatide. But the concept didn't change. The concept was everyone starts on metformin, and then you add things to metformin. And there's nothing wrong with metformin. I love metformin. I think metformin is a great drug. It's been around a long time, and it does have significant benefit. But times are changing. We have drugs now that can address certain aspects of diabetes care. For example, if you have a patient who's obese, we have drugs that help them lose weight. If the patient has a history of a stroke, we have drugs that reduce the risk of stroke. If the patient has heart failure, we have drugs that reduce the risk of hospitalization or death as a result of heart failure. So it isn't about just starting metformin on everyone. It isn't. Now we have the opportunity to tailor our medical management based on whoever walks through the door, right? If it's a patient with CHF, I got something for CHF. If it's a patient with renal disease, I have something for that. These are things we did not have in the past. And that's why when you look at the new 2023 algorithm, it doesn't say start everyone on metformin. It doesn't. What does it say? It says to start or continue metformin if appropriate, but you can start with anything you want. If you have a patient, for example, with CHF, and we know that SGLT2 inhibitors, we will know because we're going to go over that. We know that SGLT2 inhibitors reduce the risk of hospitalization for heart failure, reduce the risk of cardiovascular death in patients with heart failure. Why don't we just start an SGLT2 inhibitor from the beginning? Why do we have to start with metformin, hope the patient comes back, and then add an SGLT2 inhibitor? We don't have to do that anymore. You treat what's in front of you. And if what's in front of you is renal failure or end-stage renal, or in front of you is an obese man or woman, you treat that patient. You treat whatever comes through the door, but you don't have to start with metformin. So that's the key message. If you look here, they divide it into 4 groups, right? If the patients are overweight, well, why not give them a GLP-1 or an SGLT2 inhibitor that's associated with weight loss? If they have a history of hypoglycemia, we have agents that don't cause hypoglycemia. So just keep that in mind. We not only individualize the A1C target, and we're going to talk about that, but we also individualize the diabetes management. This is just another slide from the guidelines from ACE. Once again, as I mentioned before, heart failure, we're going to think SGLT2 inhibitors. When you finish with me today, when you see a patient with heart failure, you're going to know you want to have an SGLT2 inhibitor on board. I'm going to show you why. If we have a patient with CKD, chronic kidney disease, you're going to want them on an SGLT2 inhibitor, and I'll show you why. Patients with stroke, we can have another conference in the future and talk about GLP-1, right? Great agents for A1C reduction, but also associated with significant weight loss and a significant risk reduction in terms of stroke. And then finally, in those patients with atherosclerotic disease, you can use either a GLP-1 or SGLT2 inhibitor. SGLT2 inhibitors, as you will see, are associated with reduced risk of cardiovascular death in patients with type 2 diabetes and established cardiovascular disease. So it is truly an exciting time to be an endocrinologist because we have newer tools. There's no doubt that A1C control is important. It's always going to be important. Remember, the data clearly shows that if we lower their A1C, we reduce their risk of microvascular complications. We know that. Reduction in the risk of nephropathy, reduction in the risk of neuropathy and retinopathy. But for a long time, we didn't have any diabetes drugs that could reduce macrovascular complications, cardiovascular disease, stroke. Now we do. So it is an exciting time to be an endocrinologist. And it's an exciting time to try to use all these tools in the most appropriate fashion as possible. And if you have to choose only one, well, why don't you choose the one based on your patient's needs? So it wouldn't be a diabetes lecture without just talking a little bit on how we should manage diabetes, okay? Obviously, when a diabetic walks through the door, it's lifestyle modifications, right? Weight loss, diet, exercise, smoking cessation, reduction in alcohol consumption. That's for everybody. Number two, we want them to try to lose weight. We know that increased weight, obesity is associated with insulin resistance. 5 to 10% reduction in weight can go a long way in patients with type 2 diabetes. Prediabetes, 5 to 10% reduction in weight has been associated with reduced progression to diabetes. So weight loss is always going to be important. Number three, I mentioned that earlier. You want to choose your anti-hyperglycemic therapy to reflect not only your A1C targets, but who is in front of you. Is it a patient with CHF, chronic kidney disease, overweight, or a patient even with fatty liver? We have choices now. Choice of therapy obviously has to include ease of use and access, right? Patient doesn't want to inject, you're not going to force an injection. Give them an oral agent, okay? Cost is an issue. Not every patient can afford. We cannot give every patient what we want to give them sometimes, but we do our best. Optimal A1C is still recommended less than 6.5, right? However, you want to do that without hypoglycemia. If you're going to get 6.5 because of hypoglycemia, it's not worth it, especially in older patients, patients with chronic conditions. You don't want to play with that. Hypoglycemia is what can kill your patient. There's no doubt about it. There's no other way to put it. I strive in avoiding hypoglycemia because not only can you hurt the patient, that patient will lose confidence in you. Worst thing you can do for a patient who's never used insulin is give them insulin and then watch them have a low. They'll never use insulin again. They won't trust you again. So always try to avoid hypoglycemia at all costs. We talked about glycemic targets, number 6. Number 7, get them the goal. Don't take your time. If that patient's in front of you with an A1C greater than 9, why are you going to give one agent when one agent is not going to be enough to bring them to goal? Start with 2 agents. Bring them back as soon as you can. Push them. Okay, you got to push to get that A1C down to avoid complications. Obviously, avoid hypoglycemia. CGM technology, these are the continuous glucose monitors. That's the future. Freestyle Libre, the 2, the 3, the Dexcom G6, now the Dexcom G7. All of these CGM devices are associated with A1C reduction without any change in terms of medication. What are you giving the patient? Knowledge, power. They're able now to follow their sugars without pricking their fingers. That knowledge is associated with 1% reduction in A1C, which is what we see with most diabetes medications. And then finally, we cannot forget, we got to focus on that blood pressure and we got to get that cholesterol down, okay? If you see a diabetic patient, those are the 3 things. You have to address that before that patient leaves the room. A1C reduction, blood pressure reduction, and finally, you got to get that cholesterol down. So we're going to talk about SGLT2 inhibitors. What is an SGLT2 inhibitor? It is a protein that blocks SGLT2, which is a glucose transporter located in the proximal distal tube, okay? 90% of all glucose is reabsorbed by the SGLT2 receptors in the distal tube. What does this drug do? It inhibits the SGLT2 transporter, and glucose will no longer be reabsorbed. Instead, it'll be eliminated via the kidney in the urine. Okay, so you are creating glycosuria in order to reduce glucose load in the blood. Okay, that is an SGLT2 inhibitor. It's very simple. Concept behind it is that we all have a threshold. When we were in medical school, we talked about renal thresholds, right? The renal threshold for glucose is about 180 milligrams per deciliter. What does that mean? Anything below 180 gets reabsorbed, right? You're not going to lose any glucose. However, once your blood sugar is above 180, 200, 210, your body will try to get rid of that glucose and it will be excreted in the urine. What's the problem with type 2 diabetes? I mentioned this earlier when we talked about the ominous octet from Dr. DeFranza, is that patients with type 2 diabetes, that renal threshold gets moved to the right. that renal threshold is now 240. So that means that patient has a sugar of 200 and he is not, or she is not excreting glucose in the urine. Okay, why is that? Because you see an upregulation in SGLT2 expression in patients with type 2 diabetes. So they're resorbing glucose when they shouldn't. And that's one of the reasons why the kidney is involved with type 2 diabetes and hyperglycemia. What does an SGLT2 inhibitor do? It blocks the SGLT2 transporter and it pushes that threshold all the way down to 80. So any blood sugar over 80, your body's getting rid of it. Okay, and that's how it works to reduce A1C and hyperglycemia. Now, what are the benefits? What are the benefits of SGLT2 inhibition? Well, we talked about number one, glucose excretion, that's going to lower your A1C. That's clear. Number two, when you're urinating all this glucose, you are expending calories. It will lead to weight loss. And then you're also going to get rid of sodium at the same time. So not only are you getting glucose secretion, sodium will follow it, and you will get some blood pressure reduction as well. So these are the three benefits of SGLT2 inhibition: A1C reduction, weight loss, and blood pressure reduction. Now, pros and cons, right? There's always pros and cons. Advantages, it works at all stages of diabetes. What are we talking about? We know that diabetes is a progressive disease and that islet cell function will decline over time. We know that. So it doesn't matter if you're giving a patient an SGLT2 inhibitor when they were just diagnosed or if they've had diabetes for 20 years. We're not worried about the islets. As long as they have good kidneys, they are going to get rid of the glucose. So it doesn't matter if they've had diabetes for 5 years, 20 years, 30 years, 40 years. As long as they have good kidneys and you give them an SGLT2 inhibitor, you will get A1C reduction, right? You can't say the same thing for a sulfonylurea. What do sulfonylureas do? They stimulate the pancreas to secrete insulin. Well, if you don't have a bunch of islets, if the islets you have don't secrete much, that drug's not going to work, right? So that's why it's a nice thing to have a drug whose mechanism of action is insulin independent. There's a potential for combo therapy. You can mix it with metformin. It comes with metformin. It comes mixed with a DPP-4 inhibitor, right? It's a good drug. You get weight loss. We talked about the blood pressure, and we didn't mention, but it's a very low risk of hypoglycemia. And then what did I say from the beginning? The worst thing you can do to a patient with diabetes is give them alone. And you will have very low risk when used alone or in combination with agents such as metformin, a TZD, or DPP-4. When might you see hypoglycemia? Well, if you're adding it to a sulfonylurea, you're adding it to insulin, you may get lows, right? But for the most part, if you're giving it alone, and we'll talk about this, you're giving it alone to a non-diabetic because that patient has CKD, risk of hypoglycemia is very low. So just keep that in mind. What are the concerns? Well, increased risk UTIs, increased risk of genital myocardial infections, increased risk of decay. And we're going to talk about all those things, okay? So is it safe, right? Is it safe to inhibit the SGLT2 receptor? Well, we think it is, right? And there's actually a genetic mutation in the SLC5A2 gene. When you have this mutation, that gene is responsible for encoding the SGLT2 receptor, the transponder protein. These patients don't have SGLT2, and they live with 24-hour glycosuria. So it's called familial renal glycosuria. They secrete more than 100 grams of glucose per day. And guess what? Renal function is normal. Bladder function is normal. They don't have an increased risk of diabetes. They don't have an increased risk of kidney disease. And they don't have an increased risk of UTIs. So if you just look at this mutation, it appears that it is safe, okay? So what are we going to talk about? We're going to talk about the benefits today, okay? We mentioned about A1C reduction. Remember, this is a diabetes drug. You want good A1C reduction, you will get good A1C reduction. However, now we're seeing benefits for heart failure, benefits for CKD, right? And maybe in the future, benefits for fatty liver. But today, we're going to focus on two things, on CHF and CKD, chronic kidney disease. So in 2015, we had the release of EMPA-REG. This was a cardiovascular outcome trial done in Started in 2012, I believe, finished in 2015. And it was a big deal. It was the first time ever that any diabetes drug, either oral or injectable, was associated with a decreased risk of cardiovascular events. That's never happened before, right? You could say, well, UK-PDS, if you look at the metformin group 10 years later, they had a reduction in cardiovascular risk. That's true. It took 10 years, but it's true. We're not talking about 10 years. We're talking about patients getting benefit within months in terms of reduction in cardiovascular death. And this was a landmark trial. Okay, I show you this because if you're going to read anything today, and if you haven't read this, you have to read this article, because this is what changed the game. This is the reason why people started looking at SGLT2 inhibitors and CHF. This is the reason why people started looking at SGLT2 inhibitors and CKD. It's all because of this landmark trial. Now, why was this trial even performed? Well, in 2007, Nissen published a meta-analysis where he found that rosiglitazone, Avandia, was associated with increased risk of MI and increased risk of death from cardiovascular causes. That blew everyone away, okay? And because of this, and remember, it was a meta-analysis, later on it was proved that maybe it wasn't true, but doesn't matter. FDA decided after this publication by Nissen that any new diabetes drug brought to market here in the United States needs to perform a cardiovascular outcome trial to show that there's no harm to the heart, right? It doesn't have to show the benefit, it just has to show no harm, right? And we saw that with the DPP-4 inhibitors. When they did their trial, there was no harm, right? There was no difference. But with empagliflozin, the game changed, because for the very first time, there was a difference. And it was a significant difference in terms of cardiovascular death. Now, EMPA-REG, as I mentioned, big study, 7,000 patients, 3.1 years of follow-up. And they received either 10 milligrams of empagliflozin, 25 milligrams of empagliflozin versus placebo. To be included in EMPA-REG, and this is important, you had to have type 2 diabetes and established cardiovascular disease. Not risk factor for, you had to have cardiovascular disease. History of MI, history of a stroke, history of obstruction on calf, you had to have something. What was the primary outcome? This is the same primary outcome for every single cardiovascular outcome trial. It's something called the 3-point MACE. What does that mean? That's the time until the patient either survives an MI, survives a stroke, or dies of an MI or a stroke, right? That's called the 3-point MACE. What were the secondary outcomes? Death from any cause and hospitalization for heart failure. So if you look on the right where it says 38%, that's what blew everyone away. Okay, what are we looking at there? The gray line is placebo, the red line is empagliflozin, the study drug. And you saw a 38% reduction in cardiovascular death if you had type 2 diabetes and established cardiovascular disease. That was never seen before for any diabetes drug. That's a game changer. On the left, that's the primary outcome, right? That's what all these trials have, the 3-point MACE, and there was a significant 14% reduction driven by the reduction in cardiovascular death. This blew everybody away. Now, I mentioned earlier that from EMPA-REG, everyone went crazy looking at CHF, looking at CKD. Why? Well, it turns out they decided to follow the GFR in these patients. Now, this study was not powered to evaluate chronic kidney disease, but it's a cute slide. What do you see? You see that those patients who took Jardiance 10 or Jardiance 25 at the end of the study, the end of the 3 years, had better renal function than those who took placebo. Here you're looking at GFR. And it's clear. You see the pink line, the purple line, and look at the gray line. So somehow, unexpectedly, empagliflozin slowed the progression of worsening nephropathy. Okay? Remember, this study was not powered for this, but it's a nice little slide. And this sparked interest. This is what got dapagliflozin to do their study. This is why empagliflozin is just finishing their study. Here is the other thing that came out of this study, same study. They looked at hospitalizations for heart failure. And lo and behold, 35% reduction in hospitalization for heart failure. Right? This was not the primary endpoint, but it's food for thought, right? Now we have a drug that lowers A1C, lowers your risk of cardiovascular death if you have established cardiovascular disease, and based on this data, may protect the kidney and may reduce your risk of hospitalization for heart failure if you have CHF. Okay, remember this trial, game changer. Now, there's another SGLT2 inhibitor called dapagliflozin, and this is their cardiovascular outcome trial. 17,000 participants followed over 4.2 years. And what they did was they looked at dapagliflozin 10 milligrams versus placebo, the same exact primary outcome, right? 3-point MACE. So either the time to either you survived an MI, survived a stroke, or died of an MI or a stroke. What were the secondary outcomes? They looked at renal, right? They looked at the renal progression and death from any cause. Now, here, if you look at this slide, it's interesting because it's a composite endpoint. They decided to group cardiovascular death and hospitalization for heart failure, and they found a 27% reduction. Okay, that's good, right? But look at the 3-point MACE. There was no statistical significance. So even though you want to think that every SGLT2 inhibitor is the same, and everyone's going to say, oh, this is a class effect, maybe it's not, right? Or maybe it was the study population, right? Because for DECLARE, which is a dapagliflozin study, not every patient had established cardiovascular disease. Some of them had risk factors, but not established disease. So maybe it was the population. But it's interesting that you have, again, cardiovascular benefit. And this time was driven not by reduction in cardiovascular death, but by reduction in hospitalization for heart failure, opening the door for further study. As of right now, and now we're going to talk about it, I'm going to show you the data. We have 2 SGLT2 inhibitors here in the United States, which are both approved by the FDA for the reduction of cardiovascular death or hospitalization for heart failure among patients with CHF, regardless of their ejection fraction, whether it's preserved or reduced, right? That's your old systolic or diastolic heart failure, and regardless of diabetes status. Now we have a diabetes drug doing cardiovascular things, right? Because now we show benefit, or they showed benefit, not only in patients with type 2 diabetes, but in patients without diabetes. The first study I want to talk about is Emperor Preserved. All right, Emperor Preserved is empagliflozin again, okay? And what they did was they looked at those patients with heart failure with an EF greater than 40%. That's why it's Emperor Preserved, okay? It was 10 milligrams versus placebo in addition to their usual therapy. What does that mean? That means they stayed on their beta blocker. They stayed on their spironolactone. They stayed on their ARB, on their ACE, on their LASIK, on whatever they were on, they stayed on it. The only difference was you either got Jardians or you did not. What was the primary outcome? And once again, another composite outcome. This is CV death or hospitalization for heart failure. Secondary outcomes, all hospitalizations, initial and subsequent. And look at here, rate of decline of GFR. So they wanted to show renal benefit. If you look at the data, right now we're looking at the primary endpoint. Remember, that's CV death or hospitalization for heart failure. And you see a significant reduction in CV death and hospitalization for heart failure with empagliflozin versus placebo. What's important here, and the beauty of this slide, this particular slide, is how quickly those two curves separate. Okay, we're not talking that it takes a year to see benefit. No, you're seeing benefit within a month. And when they look back at the data, they saw benefit within 18 days. So you start the patient on empagliflozin, and with 18 days, you're already getting cardiovascular benefit. That's incredible. Okay, it doesn't take a year, it doesn't take 6 months, it takes 18 days. And you see a significant difference, and that difference stays separate throughout the length of the study. When you look at hospitalizations for heart failure, it's a huge difference. This is 37% or 27%, almost 30%. I mean, this is a remarkable reduction in hospitalization for heart failure. And once again, the reduction, the benefit occurs within weeks, not months, but weeks. When they looked at those patients with reduced ejection fraction, right? EF less than 40%. Remember, these are your sicker patients, right? If they have an EF less than 40%, they have a higher risk for hospitalization, right? They usually have underlying cardiac disease, myocarditis, coronary artery disease. These are sicker patients, right? Same layout. Empagliflozin 10 versus placebo, same exact endpoints. And what did you find? Same thing, 25% reduction in cardiovascular death and hospitalization for heart failure in these patients with reduced EF, and a 30% reduction in all hospitalization, first and recurrent. So it's clear that empagliflozin, an SGLT2 inhibitor, provides significant benefit for patients with CHF. And what's important is it's with or without diabetes. There was no difference whether you had diabetes or you didn't. So this has nothing to do with the A1C, absolutely nothing. The other thing that's important is that when you talk about CHF, you have those two spectrums of disease, preserved and reduced. We all know how to treat reduced, right? We know how to treat it. Diuretics for symptomatic relief, beta blockers, spironolactone. We know how to treat it. But what about preserved? There's not much data for preserved, right? And what do most of our patients have if you check? Simply preserved, all right? Why? Because what are the risk factors for diastolic heart failure? Obesity, type 2 diabetes, hypertension. Those are the patients we see every day. So now we have a drug that can provide benefit for those patients. And I mentioned GFR, right? Everyone's getting cute now. Everyone's checking GFR now and look what happens, right? Look at the red line. You see that big drop, okay? And everyone freaks out. They get worried when they see that big drop. Yeah, it's volume depletion, right? This is diuretic. So you will always see a drop in GFR the first couple of weeks when you take an SGLT2 inhibitor. Okay, nothing to worry about. Just make sure the patients are hydrated. Okay, but what happens at the end of the day? Look at the red line at the end of the study. It's better than placebo. So empagliflozin is delaying the progression of nephropathy. Okay, obviously, again, this study was not designed for this, right? But more and more data showing that something's going on with the SGLT2 inhibitor and CKD. And clearly, there's renal protection. When you look at dapagliflozin, remember I mentioned there's two agents that are approved for this indication, is dapagliflozin and empagliflozin. The dapagliflozin study is called DAPA-HF, 4,744 patients, EF less than 40%, so that's reduced, okay? 10 milligrams of dapagliflozin versus placebo. And what was the primary outcome? A little different here. It was worsening heart failure. So that means either they got hospitalized or they went to urgent care, or cardiovascular death. Secondary outcomes, once again, there you go, worsening renal function, hospitalizations, and death from any cause. And what do you see? It's a busy slide, but on the top left, that's the primary outcome, right? 28% reduction in cardiovascular death or hospitalization for heart failure. If you look at worsening heart failure, that's letter B, same thing, almost 21% reduction. Okay, so we do see benefit with dapagliflozin for reduced. And just recently, they got the indication for preserved as well. And that study was called DELIVER. Okay, and in DELIVER, these are patients with CHF with ejection fractions greater than 40%. So this is preserved CHF with the same outcomes and basically the same results. Okay, so these drugs do help patients with congestive heart failure by reducing the risk of dying, reducing the risk of initial hospitalization, and reducing the risk of recurrent hospitalization. Now, the question is always going to be why? You know, what in the world is a diabetes drug doing treating cardiovascular conditions, right? Well, it turns out that when you inhibit the SGLT2 transporter, right? Yeah, you're going to lose glucose, right? It's going to do its job. It's going to lower A1C in diabetics. But it also causes a natriuresis, right? You're going to lose some sodium. So clearly you have blood pressure reduction, right? That decreases your preload, afterload, all the good stuff. But what else is there? Well, it turns out that the reduction in blood pressure is important, but also it turns out that it decreases sympathetic tone, right? Why do we give beta blockers to patients with CHF? To reduce their sympathetic tone. You want that heart to go slow. Well, it turns out that somehow, we don't know how yet, SGLT2 inhibitors decrease sympathetic tone. Maybe that's what's causing the benefit. Maybe it's not just the diuresis or the natriuresis. What else can it be? Well, it turns out that the mitochondria, they work better. the mitochondria of the heart. Maybe you're protecting the heart somehow by providing better functioning mitochondria. Who knows? So no one really knows how this works, but the data clearly shows that it is beneficial. Now, this is just a summary slide. The number is going to be 30%. All of these drugs, dapagliflozin and empagliflozin, will reduce the risk of hospitalization for heart failure about 30%. Okay, so top left, we saw that data with EMPA-REG, 35%. EMPEROR reduced 25%. DECLARE was 27%, and DAPA-HF 30%. Okay, so keep that in mind. If you have a patient who walks in the door with CHF, there's no reason that patient shouldn't leave taking an SGLT2 inhibitor. Okay, the data is clear. And it's not just endocrinologists. We have cardiologists prescribing empagliflozin. And that's a great thing. Okay, that means that they see the data and they're not scared to give a drug that they know is going to benefit their patient, even though it's not their drug, right? They always say, stay in your lane, right? Well, sometimes you got to get out of your lane. And that's what they're doing. They're starting to see that we got to treat the whole patient, all right? And if you have a patient with type 2 diabetes and CHF, they should be on SGLT2 inhibitor. But remember, the indication is with or without diabetes. So there's plenty of patients out there with CHF who are on empagliflozin or dapagliflozin, not for sugar, but to reduce your risk of hospitalizations. Renal outcomes. Now, we talked about this multiple times because these were secondary endpoints. You cannot get an indication from the FDA with a secondary endpoint, right? You need studies designed specifically to answer a question. And we have 3 of them. We have Credence, which looked at canagliflozin. We have DAPA-CKD, which looked at dapagliflozin. And then we have EMPA-Kidney, which looked at empagliflozin. Now, at this particular time, only dapagliflozin and, canagliflozin are approved for those patients with CKD, with or without diabetes, in terms of dapagliflozin. Empagliflozin has yet to receive the indication, but I will show you the data so that you can see. So as I mentioned, dapagliflozin has the indication to reduce the risk of sustained GFR decline, end-stage renal disease. That means either patient ends up on dialysis, GFR less than 15, or patient gets a kidney transplant, CV death, and hospitalization for heart failure in patients with or without diabetes. That's dapagliflozin. For canagliflozin, the study had all diabetics. So their indication is restricted to those patients with diabetes. You cannot give canagliflozin on label here in the United States if the patient does not have type 2 diabetes. And they too showed, in this case, reducing the risk of end-stage renal disease, doubling of serum creatinine and CV death in patients with diabetic nephropathy and albuminuria more than 300 milligrams per day. So we're going to talk about the 2 studies. The first one is DAPA-CKD, okay? Remember, this is dapagliflozin, 4,304 participants. Their GFR was between 25 and 75, okay? Their urinary albumin, the creatinine ratio, was between 200 and 5,000. Now, GFR tells you the filtration rate now, right? It tells you how bad things are, right? Urinary albumin to creatinine ratio tells you how much albumin they're beginning to spill in the urine. So what does it mean? I mean, how can you relate? Well, the GFR tells you there's a cliff, right? So the GFR will tell you how far you are from driving off the cliff, okay? The urinary albumin to creatinine ratio will tell you how fast you're going towards the cliff, right? So those 2 things are important. You can have a GFR of 50 and you think you're good, but their albumin creatinine ratio is 4,000. That means they're gonna head south real quick, okay? So those are the 2 measures they use when they talk about CKD, okay? This study was important because it was done with or without diabetes. It was dapagliflozin 10 versus placebo. And what was the primary outcome? It was a composite endpoint of either a drop in GFR of 50%, end-stage renal disease. Remember, that's either GFR less than 15, dialysis or kidney transplantation, or death from renal or cardiovascular causes. Once again, secondary endpoint, they did look at hospitalization for heart failure. And what did they find? If you look at letter A, you see a significant reduction, 39% reduction in what? In GFR decline, end-stage renal disease, or renal cardiovascular death. That is significant. In letter B, it shows up better here. When you look at all-cause mortality, 31% reduction in mortality in these patients. This is new, right? This is data that is recent. And we have so many patients with CKD. What did we have for them in the past? ACE inhibitors, ARBs, right? Well, guess what? In this study, the patient had to be on an ACE inhibitor or an ARB. So you're adding this to gold standard therapy, and you're still getting better, okay? This is a significant breakthrough in terms of CKD, okay? Now you have nephrologists, right? I mentioned cardiologists getting out of their lane. Now you have nephrologists getting out of their lane, ordering a diabetes drug in patients without diabetes to delay the progression of their CKD, okay? So this is a game changer. When you look just at GFR, this is very, very similar to what we saw in the Emperor Preserve trial, right? Where it was a secondary endpoint. What do you see? You see that initial dip in GFR. Remember, that's from volume depletion, right? Having to drink plenty of fluids. But at the end of the day, if you're on an SGLT2 inhibitor versus someone who's not, your kidneys are better, okay? It slows the progression of nephropathy. Looking at credence, right? So credence is canagliflozin. Now, canagliflozin, it's a good drug. There's no doubt it's a good drug. It just got a bad rap because when they did their cardiovascular outcome trial, and I didn't mention it here, but they found an increased risk of amputations, increased risk of fraction. I mean, people don't like that, you know? So they got a bad rap. Now, in credence, just to be clear, there was no indication that there's increased risk of amputations or increased risk of fractures, okay? But they got a bad rap. You know, they started off on the wrong foot, okay? It's tough to sell a drug that might increase your risk of getting an amputation, right? In credence, they looked at Invokana, canagliflozin, 100 milligrams. And it was 4,401 patients. And the criteria was a little different. GFR was 30 to 90 with the urinary albumin-creatinine ratio of 300 to 5,000. But you saw the same exact thing, okay? You saw a reduction in the primary endpoint, which is end-stage renal disease or doubling in creatinine. And you also found a reduction in hospitalization for heart failure, okay? I'm just saying the same thing over and over and over, but I think you're getting the picture of what these drugs can do. EMPA-KIDNEY, this is the most recent study. It was published very recently. I think it was earlier this year. That's why they have yet to receive the indication. But EMPA-KIDNEY is a little different in that the GFR cutoff in this case was all the way down to 20, right? So they had two groups, 20 to 45 and 45 to 90. And their urinary albumin-creatinine ratio, instead of being 300, was greater than 200. So you're including more patients, right? And once again, you see the same thing. With or without diabetes, you get renal benefit if you're on an SGLT2 inhibitor, in this case, empagliflozin. Once again, this is the data from EMPA-KIDNEY. So this is the same thing we saw with the other trials. Initial dip in GFR, followed by delay in progression when compared to placebo. So why is this occurring, right? We mentioned a little bit when we talked about CHF. Well, SGLT2 inhibitors do a lot of things, right? It turns out they increase red cell mass, right? They increase erythropoietin level. Maybe that has something to do, right? We know it decreases blood pressure, right? Sympathetic tone, we talked about that. It decreases sympathetic tone, all right? So there's a lot of things that might be going on to explain why this works. I kind of like this graphic a little better because it breaks it down, right? We talked about the decreased sympathetic activity from the SGLT2 inhibitors. They think it has to do something with the vagus nerve, right? And then we talk about the effect on the myocardium, on those mitochondria working better, less oxidative stress. All of these are hypothetical reasons, but at the end of the day, it works. How does it work? We won't know for a while. We may never know, okay? But the data shows that it works. So this is just a summary of all the studies we've talked about. EMPA-REG, Credence, DECLARE, DAPA-HF, and finally DAPA-CKD. Now, we mentioned hypoglycemia. Very rare. I don't worry about hypoglycemia unless you're on a sulfonylurea or if you're on insulin. What about DKA? It's possible. It's a different DKA called euglycemic DKA. These patients have blood sugars 200, 300, but they're clearly acidotic. So gotta make sure that they're type 2, right? You have a higher risk of DKA if they're type 1. This drug is not approved for type 1 diabetes, it's for type 2 diabetes. There is an increased risk of UTIs, but the biggest side effect is going to be increased risk of genital mycotic infections, more in women and uncircumcised men. Okay. If a patient gets an infection, I treat it, but I let them know before I even start the drug. This may happen. And if it does happen, you got to let me know and I'll treat it. Now, if it continues to occur, if it's a monthly thing, then maybe this drug's not for that patient. You got to find something. Okay. But that should not be a contraindication. And then I mentioned briefly about bone fractures and limb amputations. Yes, we saw that in Canvas, which was the cardiovascular outcome trial for canagliflozin, but we did not see it in Credence, which is the column right next to it. Okay, so it seems like there is no increased risk in amputations or fractures with canagliflozin. And that was never seen, just to be fair, it was never seen with empagliflozin or dapagliflozin. So we go back to that first slide, right? This is one of the initial slides. When I said, when that patient walks in your door and you're going to treat their diabetes, well, you're not just going to treat their diabetes anymore, right? You're going to treat what comes through the door. If they're obese, right? Well, an SGLT2 inhibitor does promote weight loss, right? If they have CKD, data is clear. They should be on an SGLT2 inhibitor. If they have CHF, they should be on an SGLT2 inhibitor. So as I mentioned before, we have a diabetes drug providing profound cardiovascular benefits. So the future is bright. I mean, it's an exciting time. I mean, I didn't even talk about GLP-1 agonists. That's another talk you guys have to invite me for. GLP-1 is changing the world. Why can't you use them together, right? Imagine using a GLP-1 and an SGLT2 inhibitor. Now, I know they're expensive. I got you. But that's the perfect world, right? That's diabetes care for the future. You know, it's super exciting to be an endo right now, okay? Because we can do something about that very thing that hurts our patients, right? Remember, 2 out of every 3 diabetics will die of a cardiovascular event. And now we have something we can do to try to prevent that. At the same time, preventing the risk of microvascular complications, right? By always remembering that A1C reduction is key for the reduction of microvascular complications. And now we have these 2 agents, especially the SGLT2 inhibitors, for those patients with CHF, cardiovascular disease, or chronic kidney disease. So that's it. That's the last slide. That's all I have. So I want to thank Baptist International. It's been a pleasure. I look forward to doing this again in the future. Thank you so much for your time.
Thank you so very much, Dr. Alejandro. You have no idea how much I've smiled as you were actually presenting. Exciting time indeed for endocrinology, exciting time for our society, especially because diabetes has always been in the back of our minds, especially in the medical field. And we know how detrimental it is to our communities at large, especially in the communities that we serve in Latin America and others, where they do not have necessarily access to great treatments as the ones that you have presented today. Honestly, we've been talking forever about those incredible pearls that you reminded us. You know, reduce A1C, keep your eyes on the blood pressure, reduce the blood pressure, and by all means, look into ways of actually reducing cholesterol. I mean, we've known that since the inception, right? Since we became student doctors, and now more than ever, it's important for all of us to remember that these 3 components are extremely important for us to keep in mind. What a great summary of these medications, especially the ones that you talked about in this category. 38% reduction in cardiovascular mortality. Wow, that is mind-boggling. And you said also something extremely important that I hope that all our colleagues actually captured. which is now it is not stay in your lane type of situation. Now it is an interdisciplinary approach to patient's care. Everybody is responsible for actually being committed to getting to the bottom of a condition or disease. And why not? If a cardiovascular physician has the ability of prescribing these medications because of CHF, I mean, by all means do it. So, Doctor, thank you so very much. This is so enlightening, and I loved how you placed it. Patient with CHF, SGLT2 inhibitors, no ifs or buts. Wow. And then at the end, you said, I'm not worried about hypoglycemia. In the past, has always been in the back of our minds as well. How do we control it? So again, these two components, I am so happy that you focus on them, because obviously CHF is one of the conditions that from the past 20 years we've been looking into, and we haven't found a way of actually getting some light at the end of the tunnel. Obviously cardiovascular treatments and so on, but now with the advent of these new treatments, we can actually do a double whammy, if I may, diabetes and CHF. So I wanted just to recapitulate that, because in your realm of practice, doctor, I know that the armamentarium that you have is amazing. And the selection of patients obviously requires your level of expertise, requires someone to understand, you know, these are the conditions that you are suffering from, therefore this medication is better. It's not like one shoe will fit everybody.
Correct.
Now, lately, doctor, if we were to put these SGLT2 inhibitors aside for just one moment, because there has been a lot of noise about Ozempic and the likes, and what it has done to the reduction in weight for many in the United States and of course throughout the world. But what is your sentiment in regards to this medication? Because obviously you have heard also of companies that have closed, nutrition companies that closed because of Ozempic. They're allocating that to Ozempic. So what's your feeling about that?
Well, there is no doubt that Ozempic is a game changer. Just like SGLT2 inhibitors are game changers for CKD and CHF, semaglutide is a game changer. Now, why do I say game changer? Because you do get reduction in cardiovascular death as well with semaglutide. You get more reduction in stroke with semaglutide, but you get something special, and that's the opportunity for significant weight loss, okay? Significant weight loss, while at the same time getting significant A1C reduction. A drug that's once a week, so obviously that improves adherence. If you look at the guidelines, you have a patient who's uncontrolled, the guidelines suggest for A1C reduction, what's the most powerful combination? It's insulin and a GLP-1 agonist. These drugs are changing the paradigm for diabetes care. And I know everyone wants to use it because you lose weight. I know that. I understand that. But you have to understand one thing with these drugs. What happens when you stop the semaglutide? You're going to gain the weight, okay? So you have to be careful. Okay, so this is not a drug that's you're gonna lose the weight, it'll never come back. No, maybe lose the weight and then try your best to maintain what you want, right? All that weight you got off. But these drugs for diabetics, amazing. GLP-1, and we can talk about in the future the GLP-1 GIP agent right now, the Mounjaro, right? Tirzepatide. I mean, it's amazing what's coming out. But those drugs are going to be the future for diabetes management, and a lot of people think they should be the first injectable.
Indeed, and again, I mean, the striking similarities in some of these medications and the actions are obviously patent, especially in the control of the A1C and the control of glucose, but more importantly, the side effects, so-called side effects, you know, weight reduction, control of other diseases such as CHF and CKD. Now, do you see Have you seen a widely used approach to the SGLT inhibitors at this point, or
Oh, yes, yes,
something
yes.
that is beginning?
It's remarkable the amount of patients that are coming to see me and they're already on an SGLT2 inhibitor, right? You would think that a drug like that, people would be scared to use, right? Because they're not familiar. It's an endocrine drug, right?
Right.
No, they're coming, they're already on it. I see people in the hospital, patients in the hospital, they consult me on their diabetes. They have CHF, and guess what? They're already on an SGLT2 inhibitor.
Wow.
So the word is getting out there. And my partners with nephrology, I mean, they're using it like, I mean, I don't want to say like candy, but remember, for a long time, all we had was ACE inhibitors and ARBs.
Exactly.
That's
Exactly.
it. Now we have something we can add to it to provide
Right.
further benefit. So it's exciting.
And just move the patient to dialysis if it doesn't work.
Yeah, and you know, that's what we got to try to avoid. We got to try to
Exactly.
avoid, and maybe this is the drug that'll reduce that. It's amazing. You look at new construction sites and you think, oh gosh, they're building a restaurant. No, they're building a dialysis center. That's sad. It's sad, but
It
that's
is.
what's happening. You know.
It is indeed. The amount of readmissions, as you know, that we receive in our hospital system is astronomical still, simply because we know that these conditions can be at least controlled or prevented. So honestly, I am very excited for you and for all of us, because we have experts like you in the midst of our system. Doctor, we can keep you forever talking about these incredible things, but we know you have a really, really busy schedule. I particularly would like to thank you on behalf of our entire team for accepting our invitation, and definitely keep that in mind. We will invite you for our next symposium or conference. And to all of you that participated today, thank you so much. If you do have additional questions for Dr. Alejandro, please make sure to send them to BHIWebinars@baptisthealth.net. I'll make sure to forward those to Dr. Alejandro for him to respond back and give you some indications as of what to do with some of those questions that you have. And to all those that are patients that are joining us today and would like to actually see Dr. Angel Alejandro, please make sure to contact our office at international@baptisthealth.net. We will be more than happy to set you up in an appointment with him. We look forward to seeing you all in our next medical lecture series, which is scheduled for August 23rd, 2023, of course. Thank you once again. Have a great afternoon, and thank you, Dr. Alejandro. Have a wonderful.
Thank you.
Thank
Everyone,
you.
take care.